Hi all, and welcome to the Rewalk clinical webinar. I'm here with the Professor Luciano Bissolotti. Hi, Professor.
Thank you, Sandro, for introducing me. Good afternoon to everyone. My name is Luciano Bissolotti. I'm a physiologist. I'm the head of the rehabilitation service here in the Domsoltis Clinic. Me, myself, and my colleagues are really interested with this type of technology, and we do perform gait analysis and movement analysis in our daily routine. Here today with you just to talk about movement analysis with the G sensor, the Rewalk, that we use during our interdisciplinary rehabilitation process. I prepared for you just 3 clinical cases just to share with you some knowledge about the use of this technology in the field of rehabilitation. Actually, today we'll be talking about the use of inertial accelerometer technology applied to the field of rehabilitation with a specific reference to the use of Rewalk in 3 different types of patients. The one with an incomplete spinal cord injury. The other patient is affected by a stroke, and the third patient affected by Parkinson's disease. We'll be taking a few minutes just to provide some final remarks and the conclusion of the session. Actually, every one of us during our daily routine is actually needing to provide an objective and instrumental evaluation to what we are doing with our patients. We want to have and to gather a clear and objective assessment about what the patient is able to do, about the patient's performance. Today, we especially referring to walking ability. I want to share with you some data coming from the use of Rewalk, because Rewalk can be applied to gait analysis in the clinical setting, in our gym, in our gait lab, but we can use even this device just to explore the ability to walk on an uneven surface, in a hallway, or even on grass with our patients. We need to provide a formal and objective evaluation strictly in under a very, very precise cost-effective ratio evaluation, because we don't have very much time. We have problem with the money coming from the budget. We have many things to do with our patients and during our daily routine. We need to complete our clinical report in a very fast but effective way, because we want to provide a formal evaluation without wasting too many minutes or too much time and money to do it. Nowadays, this type of technology provided by the Rewalk sensor can provide an instrumental, objective, and multidimensional evaluation of our patient's abilities. We can use 2 different families of protocol, the one coming from G sensor, the one coming from G Stadio. The G sensor protocols are mainly devoted to the gait analysis with the Walk Plus, the time up and go test evaluation, instrumental evaluation, the 6-minute walking test, instrumental evaluation, and we can have data coming from the turn test, the run test, and the jump test with our patients. All the data are transferred to the laptop and to the computer by a Bluetooth connection. We don't have any cables, and we can use the Rewalk with a lot of our patients. We can use the Rewalk in the orthopedic rehabilitation field, in the neuro rehab, for prosthetics evaluation, as we are providing the prescription of a prosthesis to our patients, or orthotics prescription. But we can use even this device even in the field of geriatric rehabilitation and in the evaluation of our elderly. Finally, we can have reliable and an accurate analysis of our patient's performance thanks to this type of technology. This type of technology, as we know probably, is actually strongly supported by the literature. The accelerometric gait analysis is actually supported by more than 300 papers published in PubMed. We can use it certainly to evaluate gait performance in the gait lab, in the gym, but even in daily life situation and setting, such as the home of the patient, or even outside in the garden or on the concrete, for example. The Walk Plus protocol clearly needs to be supported by an accurate positioning of the sensor, because we have just to provide an accurate performance while we are placing the sensor at S1 level with our patients, because in this way the assessment of gait will be strongly supported by all the possible inertial and accelerometer provided by the system. We can use this sensor even during the term, because the system is able to provide this data. The Walk Plus protocol is able to give us spatio-temporal gait parameters, kinematic parameters, as for the global or side-to-side evaluation of the lower limb performance during the gait cycle. And the G-Walk and the G-Sensor is providing us a global evaluation of the gait performance derived by the index of symmetry and the index of propulsion. And we'll be in a few minutes watching this type of evaluation. We can have even data about pelvis kinematic, because the pelvis kinematic on the three planes of the space can be evaluated by this accelerometer. As I was saying you just before, I do apologize for some Italian words, but we can have a global assessment of in our gait analysis report. We can have the duration of the trial, 40 seconds in this case. We can have an assessment of the cadence, 130 strides per minute. We can have an assessment of a gait speed, 1.46 meters per second, and we can have even a temporal analysis as typically provided by the standard gait analysis report, the duration of the cycles, the length of the cycle, the absolute and relative values inside all the gait cycles, such as the stance phase, the swing phase, the double support phase, or the single support phase. So it's very nice, because in this way we are able to receive data according the single step cycle and the step-to-step cycle symmetry, or the stride cycle for both the sides. As you can see here, this is the typical image of the analysis derived by the use of the Walk Plus protocol. You have here the sub-analysis of a few steps from one side, the left one and the right one. As you can see, we can have data about the gait and the step sequence, for each side, and we can have a judgment about step variability for each side, or we can have a judgment about the side-to-side symmetry for both sides, because the system is able to explore and to provide an evaluation in the domain of time. We can have a precise assessment of when and how much and how fast, as we'll be able to see in a few minutes, the patient is able to turn and to come back in the same direction where he was coming from. The system is able to precisely individuate the initial contact on the interested step, in this case the right one, or even the initial swing phase. In this way, the evaluation of stance and swing phase can be really well discriminated by the system. This type of discrimination is coming from the evaluation of acceleration parameter from the left, for the left and right side. As you can see in this graph and this picture, the clinician is able, and we are able to see what's going on the gait cycle of the left and right side from the stance to swing phase. And meanwhile, at the same time, from side to side, we can appreciate what is the index of symmetry between the both sides, because it's very easy just to receive a data, but even a clinical images, such as the one of the EKG, for example, of the index of symmetry as a global parameters that can be used to express a judgment, clinical judgment about the quality of gait cycle with our patient. We can perform an evaluation in the domain of space, in the spatial domain, because just examining the single phase support phase will be able, inside the gait cycle, to discriminate what's going on in terms of propulsionability in the double support, but mainly clearly in the single support phase, how much the patient is able to provide an adequate and accurate and effective propulsion to walk in our hallway. In this case, once again, we'll be able to have data about the volume, the quantity of motion that the patient is able to provide. It's very interesting to see with you and to evaluate with you 3 different case studies. First of all, we have one of our patients affected by a spinal cord injury, and during last years we got along with the Rewalk technology. We use exoskeleton just to induce gait in our complete or incomplete spinal cord injury patients. In this case, I want to present you the case of this gentleman. He is a 41 years old man. The AS score is C, and the lower limb motor score is 12 on 50, with 8 months of history beyond his shoulder. The Wishy-2 score is 1 on 20. Unfortunately, he doesn't have any minimal ability to walk even with KFO, just to make some standing. We are using actually this technology just not only inside the gym, but even outside our hospital. And thanks to the Rewalk, we can use just a laptop and the G sensor applied on the pelvis to receive data about the quality of gait even outside, just being able to provide an accurate evaluation in the sagittal plane, in the horizontal plane, the coronal one, from side to side and from stance to swing phase, and even evaluating what is the alignment of the trunk compared with the lower limb. In this case, I'm presenting you data from the temporal parameters coming from the G-Walk during the first 100 meters and the last 100 meters from 200 to 300 meters. As you can see here, during the first 100 meters, patient completed this trial in 234 seconds at a cadence of 55 strides per minute with a walking speed of 0.61 meter per second. As well, the patient was able to maintain this same performance during the last 100 meters of the evaluation. And this is an objective way to get data about the ability of the patient in maintaining the same standard and standardized task exercise while he's using the exoskeleton. This is important, particularly if you want to provide an objective evaluation about the possibility to prescribe the exoskeleton even while the patient is discharged from the hospital and he has to go back to home. In the temporal domain, we are able to evaluate what is the symmetry between the left and the right side, what is the index of symmetry while the patient is using the exoskeleton during the first 100 meters and the last 100 meters. As you can see here, our patient is able to maintain the same pattern of motion from the left to the right side and from the first to the last 100 meters of gait. It is not only a matter of volume, but even it is a matter of quality in the use of the exoskeleton. We have data in terms of propulsionability, and as you can see here, once again, the performance with the exoskeleton is very symmetric from the beginning to the end of the task and from the left to the right side. So symmetry, quality, it means just to receive an objective certification of the ability of the patient in performing with the exoskeleton. Actually, here you can see what's going on in terms of pelvis adaptation in the use of Rewalk on the sagittal plane in terms of antiversion or retroversion. As you can see clearly, as if you remind the image I was showing you before, the patient is typically constantly adapted to maintain a certain positive imbalance of the trunk because he has to use the exoskeleton just to provide the input in maintaining step-to-step performance. And in this case, as you can see, from the beginning to the end of the test, the patient is even able to slightly improve the index of symmetry. It means that with a less range of motion of the trunk, is able to induce the same amount of movement. And this is very important because less amount of trunk use means more efficiency under the biomechanic point of view. And the report from the Rewalk is showing us this result. Another multidimensional assessment of the motor performance can be provided with patients affected by Parkinson's disease. In this case, we have a 71-year-old gentleman. He's affected by Parkinson's disease. At least he's being affected by this disease for 28 years. It's a lot of time, but he's maintaining 2.5 of ONIA classification and 10 points in the motor score of the UPDRS section. Motor section, sorry, and 22 and 28 and the Tinetti score. We evaluated his ability to move his body with an instrumental evaluation using the G-Walk during the time up and go test, the 10-meter test, and the 6-minute walking test. As we know from the literature, it's very important to provide an objective evaluation with these ecological assessment tools because the 6-minute walking test is strictly and well related to quality of life with our patients. Another interesting consideration is coming from the literature in aging clinical experimental research just this year. These colleagues provided an evaluation of turning characteristics stratified according to the severity of Parkinson's disease in the gait lab during the time up and go test. As we can see here clearly, the time up and go test can be, during the turning phase, can be considered helpful to measuring the ability of our patient in turning and in case of different severity levels of our Parkinson's disease patient. This is very important because this is strictly related to the risk of fall with our patients. As you can see here, we can perform an instrumental evaluation of the timed up and go test, but we can provide a very accurate sub-analysis of all the different components of the time up and go test, the rise up, walking to arrive to 3 meters distance, turning back, and then coming back to the chair. As you can see here, we can have data about the first phase of the test, the last one, the global duration of the test, and we can have even evaluation of the intermediate rotation, because we can receive data about the peak, the speed peak of rotation, and the average velocity of rotation during the turning in the time up and go test. During the 10-meter test, as we know from our clinical experience, our patients, according to the severity of their disease, are typically presenting a low level of symmetry. This patient has an index of symmetry of 85 and not 98%. It means that from the left to the right side, and the right side is presenting actually the worst possible performance. We have a very low symmetry even in the sagittal, on the sagittal plane in terms of pelvis movement, because we have 72% on the sagittal plane, and we can provide and we can perform this evaluation in the on or in the off phase, at the beginning, at the end of the rehabilitation process, with or without a certain type of shoes, if we want to evaluate whether this certain type of therapeutic intervention is providing an improvement in the performance with our patients. We can even perform the 6-minute walking test. We have evaluation of the distance. We have a general and global index of symmetry, and the average speed, the cadence, and the length of the gait cycle in meters. But we can have even a more particular evaluation of every single piece of our 30 meters all the way, because here we have 17 different parts of the 6-minute walking test evaluated by the Rewalk. As you can see here, the global symmetry, as expected, is going to be decreased by the time. So we have to pay attention here, because we can eventually decide to advise the patient that while walking in this condition, after 350 meters, is needing to stop there for a few seconds and then to walk again in the aim to regain a certain symmetry, or eventually we can make some further training or rehabilitation to improve the symmetry even after 400 meters of distance. We can see that the gait cycle duration is pretty stable in the second phase, but is going to be reduced than the beginning of the trial. The customary gait speed is increasing by the time. It means that probably the patient is exploiting his ability in the propulsive phase, but is losing in the quality, and probably the falling is increasing by the meters. I want to present, and then I'll be certainly happy to answer to your questions in a few minutes. I want to present you some data coming from the use of the G sensor, the G-Walk, with the integration with the surface EMG analysis system. Actually, nowadays, during the 10 meters test, or any other distance that you want to use to provide the gait analysis with your patients, you can receive at the same time data coming from the EMG probes of the system. The G-Walk can be integrated with 8 wireless EMG probes, and we used these analysis during walking with this gentleman. He is a patient, he's a 40 years old patient with a left hemiparesis, with a functional evaluation classification of 5 on 5, a motricity index of the lower limb, of the affected lower limb, of 67 on 100, with 4 years of history in the clinical report, and 18 points on 28 in the TNT score. This is his ability to walk in our gym, in our lab. Nothing special, nothing strange. We saw a lot of cases, but we can move further from the observational analysis to the instrumental analysis. And in 5 minutes, we can have objective data, because we can have data about the cycle time, the start time, that typically is depressed than the healthy side, the swing phase, or even some further sub-analysis of the first double support phase that is typically reduced in these patients, and the reduction even of the single support phase on the left side. At this point, we can have an integration of this data, even with a support in the clinical decision process coming from the surface EMG analysis. As you can see in the right, on the right healthy side, the EMG analysis is performing well. On the left side, the EMG showing us that we have an in phase, but poor activation of the tibialis anterior. We have the absence of the double peak at the initial contact. We don't have the double peak of the tibialis anterior. We have a poor, but in phase, activation of the left gastrocnemius medialis. And we have some clonic spikes at the solus. They are in phase, but with clonic activities. So eventually we can decide to treat or not to treat with botulinum toxin injection, the left solus, but we can even decide to use functional electrical stimulation or any other type of tape or ptosis to improve the dorsiflexion phase. And the patient in this case can be even evaluated side to side whether we are using a functional electrical stimulation or not, or at the same time if the patient is presenting a co-activation pattern. So at the end, why I decided and we decided to use the technology in our rehab center? Because this is a smart technology, it's wearable, it's multitasking, as you can see, it's multi-parametric, it's very fast and cost effective, because in a few minutes you can get a lot of data about your patient. You don't need a huge gait lab system, and you have an objective evaluation. Clearly the medical history, the clinical examination, and the functional evaluation will be always the first step of our evaluation process about our patients, but probably by the time will be necessary just to integrate in a more systematic way the use of this type of technology as a first level approach in evaluation and the assessment of our patients, because we need to evaluate their disability and the effectiveness of rehabilitation in a very fast way. We can provide some more data about the use of botulinum toxin, orthosis, or taping prescription, maybe integrating it with multi-channel CMG. Gate lab technology will be always living, but will be mainly devoted to patients that have to be candidated into functional surgery. We have a lot of advantages. We have some limits because with a very low gate speed, the patients below the 0.3 meter per second, we have some difficulties, and we don't have kinetic data, but we have a lot of advantages. So thank you very much for your attention. Hope you enjoyed the presentation. I'll be ready and happy to answer in your question. Thanks a lot.